Right, let's go ahead and get started. Hello, everyone. My name is Jeanette Dill. I am a faculty member at the University of Minnesota and the Deputy Director of CWORPH, which I will describe more in just a second. Welcome to the CWORPH webinar series. I believe this is the 6th webinar that we've given this year as part of this series. Today we have 2 talks. The first is on the consequences of state remote work policies on rural public health. And then the second one is the identification of potential public health workforce data sets and their utility for future research. All right, CWORPH stands for the Consortium for Workforce Research in Public Health. CWORPH brings together top research teams from 6 universities to conduct research in the areas of public health, workforce, and systems, and these include the University of Minnesota, Columbia University, East Tennessee State University, Indiana University, Johns Hopkins, and the University of Washington. CWORPH is the home of the HRSA and CDC-funded Public Health Workforce Research Center, the only health workforce research center that focuses specifically on the public health workforce. And the work being presented today is part of the PHWRC Year 3 projects. CWORPH is also funded by the CDC National Partners Cooperative Agreement to support recruitment and retention in local public health agencies. And CWORPH recently completed a recent national enumeration of the public health workforce, and you can click on the link there to learn more. All right, some quick guidelines for the session. Please use the Zoom Q&A window to ask questions. Most questions will be held until the end of the presentation, but feel free to put them in at any point. And then some presenters may respond to some questions in the Q&A window during the program when they've completed their respective sections. The chat may be used to message the host about any technical issues, and closed captioning is available on the webinar, and settings can be accessed in the Zoom application toolbar on your screen. Following the webinar, slides will be emailed shortly to all attendees, and the audio and video of this webinar will be recorded and shared on our YouTube channel, and you're welcome to find it there. And then you can subscribe to or email to our email list to receive alerts about additional webinars and projects. And the link will be posted in the chat. All right. We have a variety of speakers here today. The first is Betty Bekemeier, who's the director of the Northwest Center for Public Health Practice, and she's at the University of Washington School of Public Health. She is joined by Paula Kett, who is a research assistant professor and the deputy director of the UW Center for Health Workforce Studies and the Center on Health Equity. And she's also at the University of Washington in the School of Public Health. And then for our second talk, we're joined by JP Leider, who is the founding director of the Center for Public Health Systems and is the director of CWORPH here at the University of Minnesota. And then Gabriela Lazalde, who is a researcher at the Center for Public Health Systems, and I believe is going to be presenting today. Right, I'm going to turn it over to our first group.
Great, I will get my...
So, hi everybody, Paula, thanks for setting. This is Paula Kett, and I will be presenting. Paula is the lead author of this study, so I want to really acknowledge that. And I'll be kicking us off. But we did our study on consequences of remote work and how state-level remote work policies are impacting rural public health practice. So to start us off, I mean, many workplaces today offer remote work options, and we all know that. In 2024, they found that 22.9% of the U.S. workforce was reporting that they were working some of the time remotely in 2024. So this is also increasingly common among public health agencies. So, and that increases the pool of potential candidates for positions, including people already working in health departments elsewhere. When this occurs among state health departments, fully or partially hybrid remote work policies could have the potential to particularly challenge or benefit rural health departments. Rural health departments are agencies that on the one hand have a particularly difficult time filling positions, but on the other hand could also perhaps benefit from state health department staff who are well versed in understanding rural public health needs and end up in state health departments. So the study was conducted in response to us hearing a lot about some of the possible ripple effects, positive and negative, that seem to be arising from remote work practices at the state level. So since little is known regarding how remote work and its relatively new implementation in many public health agencies, how that is impacting rural local health departments, our study sought to explore public health perspectives on remote work, specifically among rural local health department leaders, and how remote work practices among their state health departments may be affecting their efforts. So for this study, it was largely qualitative. We conducted qualitative interviews with rural local health department leaders from states that we understood to have state health department policies supporting various forms of remote work. And we understood this through discussions with ASTO folks. We did thematic analysis to identify and refine themes from those interviews. And these themes represent rural health department perspectives. So have that in mind that our findings are from that lens. Nonetheless, we think everyone can learn from these findings. They've been pretty interesting. So while the qualitative interviews were our primary source of data, we also examined 2024 PHWINS, the Public Health Workforce Interests and Needs National Survey data, to look for things like differences between job satisfaction and risk of turnover among remote versus non-remote state health departments and local health department staff using sample weights. And we limited what we looked at for these survey data based on themes that arose from the qualitative data. So those kind of guided our selection of variables. In terms of our interviews, approximately 2/3 of the sample was identified as females, with most of them for over 40 years of age. All interviewees identified as white, and all had a fair amount of experience in public health and in rural public health specifically. In terms of local health department and state health department level remote work policies, this green chart on the left describes the distribution of remote policies that participants talked about at their rural health department. The yellow wheel on the right describes what our rural local health department interview participants understood to be their state's remote work policies. So as you can see on the green chart here, none of the participants we spoke to had a fully remote option for their staff, but half of them had a hybrid policy, something like 1 day a week or leave early on Fridays, etc., with the rest of them having a mix of all in person or situational. Similarly, half of our interviewees reported, our rural local health department interviewees reported they worked in a state which they thought was fully remote. See this dark brown portion of this yellow chart. And about a quarter of our interviewees were unsure of what their state's policy was. So that's that very pale portion of the yellow chart. But we kind of focused on those that had more of a fully remote policy in their states. So these were some of we had about 3 themes that developed out of our conversations with these rural local health departments. The first focused on participants' description of the impact of working in a state where their state health department permitted at least some remote work. So the first theme was around accessibility. They talked about the experience of participants, it was kind of mixed, with some stated they had more interaction with their state liaison, with this first quote illustrating that, that quote, that they may be a little more willing to come and meet with us in person or travel to get together because they're located all over the state now. Others had the opposite experience where they found it was more difficult to get in touch with their state partner, as illustrated here. We asked a question, a couple days later, the state person reaches back out to us, but we needed that question answered 2 days ago, and now it's too late. So it was kind of mixed in terms of accessibility. Broadly, most participants were unclear about what exactly their state health department's policy was. And beyond this, they weren't clear what they should expect when a state person was remote with respect to their responsiveness, their presence for certain meetings, things like that. Participants also pointed to remote work being available at the state as being another reason for losing staff from their agencies who went to work at the state. Most were quick to point out that this wasn't the sole reason a staff may have moved to their state agency. They also cited, pay, benefits, flexibility at a state agency. But they stated that now many staff could get these better paying jobs without moving, which increased the incentive. Participants described the strain that this created for them, as illustrated by this quote. People are definitely going to the state, and it does feel like we're training them, and then they go to the state. You spend a lot of dollars, a lot of time, etc. And I'm going to pass this over to Paula to talk a little more about their own opinions of their own remote work.
Yes. So we also spoke to rural health, local health department leaders about implementing remote work in their own health departments. And many cited the positives of remote work options, such as the ability to use it for recruitment and retention, the ways that it offered benefits such as flexibility to staff, and even ways that it offered staff the opportunity to be out more and be more present in the community. As one person said, I think our hybrid work policy has been huge in terms of my ability to retain staff, to keep people on, because public health wages don't tend to be the best. And so the flexibility that we can offer people is really a big incentive. There were also some reservations as well. Some cited compatibility issues with local public health work, pointing to their role as being community-based. Being remote didn't align well with this. And they also highlighted that the nature of the services provided in rural settings really necessitated being in person, that they often were providing, for example, more direct service, and that their work had a lot of oversight, as illustrated here. The ability to have oversight and to have transparency is important. We have to report to taxpayers. We are not a private entity. Local tax dollars and local legislators, our county board supervisors are all very in tune to what we do. And finally, some had concerns also about productivity, named issues around lost opportunities for collaboration on their team, on the internal, staff, as stated here. A lot of the work that we do in public health is all about that collaboration, just having organic conversations about what the needs of our community are. And so I like us to be in the office for that reason. And then kind of the last large set of themes relates to their perspectives on state-local relationship. That conversations highlighted ways that the addition of remote work policies both revealed and also exacerbated existing tensions. Participants experienced the effects of the systems operating separately, and stated that it would be helpful to have more of a coordinated system, as well as acknowledgement of the strain that rural locals experience when they lose a staff member, especially one in a more specialty area. And this quote gets at that. You want people to have opportunities, but also how is the system gaining when we're just losing here? It's hard that you don't get resentful of your state partner. It's like, really, did you have to take their one and only epidemiologist? And then participants highlighted how valuable it is to have the expertise from the state, with some noting that they would like more of this. But at the same time, finding that there was some concern that when this expertise was provided, it could come without understanding of the local context. And participants also shared a desire for more of their local expertise to be used and to have more of a partnership approach with the state. And this quote really gets at that desire for expertise, where our state really needs to step up their game and is in bringing their expertise to local health jurisdictions, not just to share the knowledge and skill building, but also to make that connection of emphasizing we're here as the resource. So, like Betty said, we took these major themes to kind of as a guide for looking at PH Wins data. And quantitative analyses overall somewhat lined up with what we were hearing anecdotally in terms of the proportion of those in rural and urban or state settings who are working remote. So as you can see here, only 7% of local staff reported in rural areas reported working remotely, compared to 15% of local staff in urban settings, and then 52% at the state. 17% of rural staff who are currently in person reported preferring to be remote. However, you can also see that among rural staff, that's lower than when we're looking at urban, where it was 26% of those who were in person preferring to be remote, and then 36% at the state. So it kind of goes up sequentially with those groups. And then when looking at plans to stay or leave, we don't see that remote policies were a huge driver either way, particularly when we're looking kind of on a national level. And then locally, when we're 17% of rural staff reported that remote policies were a reason for staying or leaving, compared to 27% of those in urban settings, kind of both. And then when we look at those in state health departments, 54% reported, they were staying because of remote, and 25% reported planning to leave because of lack of remote policies. We also looked at differences in tenure between those working remote, and found that those with lower tenure, 0 to 5 years, were more often working remote, 14.1% of that population, compared to 9.2% in 21 plus year group. Really no significant associations. We just looked at this among local health department staff, and I didn't share this here. No significant differences between those working remote or not remote in terms of those job satisfaction, et cetera, some of those job outcomes that we looked at. So overall, there were really kind of mixed perspectives from locals on the impact of state health department remote policies. At times finding that it could help and did help increase accessibility, but other times also created barriers or interrupted communication. Participants found that remote work was valuable and could see the value of remote work, but also found that particularly in rural settings, there may be limitations in being able to use it. And then that recruitment of local staff to state health departments can place a particular strain on rural local public health. Broadly, perspectives really evidence some ongoing tensions in state health department, local health department relationship, and provide an opportunity to consider ways to strengthen this relationship. First is really considering how remote policies are implemented with respect to accessibility of staff. No suggestion from any participant was to eliminate remote policies. They were not against having these, but rather wanting some intentionality with implementation. Really ensuring that there's clear pathways of communication between state health departments and local health departments. And this is regardless of remote policies, but may be especially important in that context. And then finally, for those rural local health department staff that do move to a state position, really finding ways to leverage their expertise as a way to grow a state health department's connection to and understanding of rural local health departments and communities. So that is our study. Thank you so much, and to our study team. We are happy to, we'll answer questions today. This is also our contact information for further questions in the future. So thank you so much.
Great. Thanks, Paula. We're going to transition over to our second presentation. Gabriela, go ahead and share your screen.
Sure. All right. Well, hello again, and thank you all for attending. I'm Gabriela Lazalde. I'm a researcher at the University of Minnesota Center for Public Health Systems, and I'll be sharing on this work that I did alongside JP Leider, who wasn't able to join today, and our research assistants, Nicole, Audrey, and Hawking. So to begin, I wanted to share why we were conducting this study. So first, we wanted to be able to describe the state of the public health workforce, including strengths and limitations within public health agencies, because we know that their work is needed to keep communities healthy. Second, as a public health researcher and as us, public health researchers and practitioners, we know it is important to assess trends and emerging threats to the workforce to take any needed actions to keep it as robust as possible. And third, we wanted to make sure that we're using existing data resources wisely, especially at this time of financial constraints. We don't want to duplicate efforts or ask people who are very busy to participate in yet another survey if we don't need them to. So given this importance, why do we not already have a centralized resource for public health workforce data? So first, the public health workforce is very broad and works on many levels, which contributes to why we don't have a single system that collects all of these data. Fortunately, there are some very useful data sources that can provide information on some aspects of the public health workforce. So these include the De Beaumont Foundation's Public Health Workforce Interest and Needs Survey, PHWINS, and the profile studies managed by ASTO and NACCHO. Among others, these data sources are used frequently by researchers, yet these tentpole studies do have some limitations in their samples and in the content that they cover. In 2009, there was a previous attempt by the late Douglas Scotchfield and his team at the University of Kentucky to create such a repository for public health systems and services researchers to use, but this resource is no longer available. Plus, a lot has changed in public health and in how data are collected and shared since then. So we designed an updated study to address these key questions. So first, what public health services and systems datasets exist? What datasets are specifically useful for workforce analysis? And what types of research questions and analyses do these datasets support? So these questions were shaped by the 2023 Academy Health Research Agenda, which among other goals called for public health systems and services researchers to continue to provide evidence that can help improve public health. As highlighted here, including in the workforce domain. The other domains shown in this chart, cross-sector partnerships and engagement, data and information technology, financing and resources, law and governance and law and governance and communication and narrative are also relevant to the workforce domain, and we'll come back to these domains again shortly. So the objectives of our study were to assess the state of current public health workforce datasets and to create relevant resources about these datasets that we could then disseminate to scholars in this field. And now I'll talk about how we did this. So we used a multi-method approach to collecting data. For our literature review, we borrowed search strategies designed by my colleague Jason Orr for a forthcoming systematic review of data describing the size and composition of the public health workforce. We also completed an environmental scan where we spoke to experts in this field, reviewed data sources identified in past projects, like the Scotchfield repository that I mentioned, and searched the websites and reports of professional organizations and government agencies. So on the right is a visual depiction of the search process. Overall, our initial literature review alone yielded over 3,000 results. But after we removed duplicates, items that weren't relevant to the United States public health workforce, and items with data sets from 2014 or earlier, we ended up with less than 200 final items that we reviewed at our level 3 final review and metadata extraction stage. So for this final review, at least 2 reviewers looked at each item. For each of the items that met our final research or our final inclusion and exclusion criteria, we extracted metadata about the data sets or data sets used within these items. So each item could have been like a specific academic study or a practice-based study that used different data sets. For each of those data sets, we identified key characteristics such as the date of the initial and the most recent data collection, the frequency of data collection, who manages access to the data, and whether any of the data are immediately accessible for use. We also described the content of the data. We wrote brief notes on the content and its potential future research applications. At this stage, we also noted whether the data sets could be located in existing data repositories like the University of Michigan's Inter-University Consortium for Political and Social Research, ICPSR, or if the item mentioned any other data repositories that had not yet been identified in the other data gathering stages. So once we collected all of our data sets in one spreadsheet, we also separated out all the repositories into another spreadsheet. And this is how we proceeded with our analysis. So first, we thematically coded the metadata text on themes and utilities from the data sets in the first spreadsheet. We also coded each data set to the best content match within those Academy Health domains that I presented earlier, and we'll come back to once again. Then from a quantitative approach, we used statistical analyses to describe the data sets further. And now I'll share some of our results. So overall, we found 85 data sets in 13 repositories that form the basis of the resources we hope to share. So 73 of those data sets were identified in the lit review and 64 in the environmental scan. Many data sets came up in both, and I will talk about those specifically next. But overall, over 90% of them had some quantitative data, and among those quantitative data sets, over 75% of those contained survey data only. So these were the 34 data sets that appeared in both the literature review and the environmental scan. The 16 in the lightest shade here were in multiple literature review items, suggesting that they may be more frequently used for academic research purposes, whereas the 22 in the darker gray were in multiple environmental scan items, which means that they might be more practice-oriented or more recent. And then the black data sets here were used multiple times in both the literature review and the environmental scan items, and that includes the ASTO and Nature Profile, PHWinds, and the National Center for Education Statistics Integrated Post-Secondary Educational Data Systems, or IPEDS. So one conclusion from this finding is that national level data sets, including the tentpole ones that we expected to see and did see, are indeed frequently used in public health research and practice currently. We also wanted to look at who manages these data sets. So 37.6% or 32 data sets are managed by professional organizations. So again, that's your ASTO, your NACHO. The same proportion are managed by government agencies. So that second bar that you see here, 24 of those are federal agencies, and the remaining 8 are state, local, and tribal agencies. 15 data sets are managed by universities, 4 by nonprofits, and then 2 are by for-profit or other types of organizations. Now our analysis started to relate to our second research question, which data sets are specifically useful to workforce analysis. So one of the ways that we wanted to measure that was by gauging how accessible the data sets were. So we found that over half had either partial or full public data access, but 45% of our data sets had either no data access and no clear way of obtaining that data access. So there wasn't a clear pathway to obtain a data use agreement or anything like that. So this suggests that while data availability might be increasing over time as there's a greater transparency as a greater push for transparency in research, there might still be limitations to accessing a significant portion of these data sets for secondary analysis. So this second analysis confirms that trend of increasing accessibility. So this far rightmost bar shows that over time, a greater proportion of data sets are increasingly accessible to researchers. So I would argue that the data sets in this rightmost category are probably have the highest relevance for current workforce analysis, since they're from a time after the significant initial impact of COVID-19. As part of our qualitative analysis, the team went through the descriptions of the data content that reviewers noted and generated these categories to describe the themes that we saw among the content of the data sets. So training and education, recruitment and retention, policy, other context and capacity and skills. So over half of the data sets focused on that bottom category of workforce capacity and skills. This graph reflects the proportion of the data sets that included content within each of these categories. And as you can see from this number adding up to more than one, a majority of the data sets fell into multiple categories. The results presented here also speak to our third research question about what types of research questions and analyses these data sets may support. So data sets that fell into the context-only category may not have as much utility as those that fit into the others. Additionally, some of the data sets in the training and education category may have limited utility depending on the scope of the data. So some of the data sets, for example, were data on results of health department specific trainings and might not have much value outside of that health department. Results from our second deductive round of coding, where we assigned data sets to the domains identified as the most important within the previously mentioned Academy Health research agenda. We found that equity was the most frequently reported theme, followed by cross-sector partnerships and engagement. Relatively few focused on the remaining themes. This suggests that additional data collection on law and governance, data and financing, and communication and narratives may be necessary to conduct further data analysis in those areas. I'll also note here that we found very few longitudinal surveys, but the surveys and data sets that we did find that have longitudinal data are some of the most frequently used. So some of the limitations of this work included potential bias in classifying and describing the data sets we identified. There also could have been some potential bias in finding the data sets in the first place. We might have missed some smaller data sets, especially if they describe only some specific sector of the public health workforce by geography or by occupation. Finally, there might have been some concerns around whether some of the larger publicly accessible data sets will remain available and how accurate they'll be given ongoing political challenges to public health data. However, we still feel that the study is useful through its generation of useful resources for researchers, especially in terms of making use of existing work and highlighting needs for more data collection in the future. So for our final steps for this project, we're finalizing our manuscript. We're putting together those repositories that will be searchable by researchers. We're seeking additional commentary on this work, and we will be doing a further dissemination of this work. And that's all I have.
Great. Thanks to all presenters. It's really great work. All right, we have one question in the chat that I'm going to begin with, and this goes to you, Paula. The question asks, when were the interviews conducted? And then do you think that any return to work policies have changed the landscape on the remote work situation?
Yeah, I think so. Interviews were conducted last, I think, March through May of 2025. And there are policies and were policies even as we were speaking with participants that were changing over time. So I do think, there were some states that at the time when we spoke to participants, after we spoke to them, instituted return to work policies at the state health department. So that was happening. A number of them still maintained a certain amount of remote work availability for a portion of staff, but maybe less extensive than had been. But there's still a number of states that are fully remote as well and have stayed that way. But I think it is a changing landscape kind of constantly. And I think, like we said, partially because it is so new, even without return to work, there's just changes in policies, I think, over time as organizations are learning what works best. But
all right, I'm going to ask Gabriela a question and then we'll come back to the remote work. Gabriela, I was curious if there were any data sets that emerged in the search that you were surprised by, ones that you hadn't known about that popped up, and were there any that you found particularly exciting that you may not have known about before?
That's a great question and one that we have gotten before about this work. So I've had some additional time to think about it. Um, because I'm relatively new to this work, I think a lot of it was new to me at the time that we were conducting this data. I think the data sources that are most exciting to me and that haven't been used as frequently as I thought they would be are potentially the USA spending data. So that's a data source that tracks all of the federal funding and where it goes. And it's kind of difficult. It can be kind of difficult to use as I'm learning through a different project, but I think it's a really robust data source if you're trying to understand where public health funding from the federal level is going and potentially trying to connect that to different outcomes. I think that's a potentially very powerful data source that is underutilized. I think there are also some data sets that are really specific to like specific public health occupations that I just wasn't super familiar with. So like there was one of the repositories actually that came up was about dentistry and about dental occupation. And it actually seems like it has a good amount of information about public health dentists in there, which I think are generally understudied as well. So maybe those are a little bit more on the obscure side, but those are some of the ones that came up that I thought were really interesting. I was also surprised to see how much work has been done to some extent with Lightcast, which is our one for-profit data source, which many of us are probably familiar with, but it aggregates data from different job posting sites and lets you kind of assess, what's happening in the public health workforce job market and hiring. And so that's another really interesting and rich source.
Cool. Is the federal spending data set, is that accessible? Is it publicly available?
It's publicly available, but like I said, it can be kind of tricky to pull down the detailed data. I personally have not done it, but we've had our data folks get some of the more detailed data for us, and it has been really useful. I don't know all the specific details of how we did it, but I know that there are many people who do have that skill, and you can get the basic information from the USA spending site pretty easily, I think.
Cool. Okay. Paula, going back to the remote work, one of the things that you talked about was the collaboration between state and local health departments. And I wondered if any of your interviewees talked about how remote work could actually support state involvement in local health departments, right? If you have employees who are working remotely, right, you have less need of a physical presence, right? So you could have someone who could provide at the state level, who could provide greater support at the local level or potentially across different local health departments, and if remote works have facilitated collaboration in that way.
I think all of them saw opportunity for that, and some experienced that and some did not. So I'd say some, did say, like we talked about, actually, the people that they spoke to most often at the state health department were actually more accessible because of being, because of being remote, they could, connect with them. Some of them ended up living closer, so actually came in person more often. They found that for some who were remote, because they weren't also traveling in person to their own office, they were willing to make kind of one-off trips periodically to come in person to rural areas where that had been more of a barrier before. But for some, their state health department liaison wasn't even living in the state. And so they felt like there was some issues related to even awareness of, contextual kind of experiences, even in the state itself. Others, and some of this was early on, they didn't have a clear contact, for the, and so they only had their office number, which didn't go anywhere at the time, so some of that was early chaos. They also said there were just some levels of unexpected, there wasn't always clear expectations for what they could expect from the state health department person. They said, sometimes they'd show up to remote meetings that were with many kind of board members, board of health members, et cetera. in the county. And Morneau is, professionally dressed and that sort of thing. And so they said there was kind of that disconnect that they felt like they could easily address,
Yeah.
just didn't always have that experience. So.
Yeah. 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 Makes sense. All right. Gabriela, you mentioned that there weren't a lot of data sets that were longitudinal, but the ones that were ones that were most often used. And so I wondered if you could speak to that a little bit. I think identifying longitudinal data it's difficult a lot of times. And so, like, can you talk about which data sets did provide that longitudinal perspective and like what does that provide for researchers?
Sure. So I think to start with the last part of that question, it's really important for researchers to understand trends over time and to potentially start trying to do some causal analyses for some of the changes that we're seeing in the public health workforce. And so having that data that reflects those changes over time consistently is really important. I think the rest of my response to the question also has to do with one of the questions in the chat, which is just around which data sets was I not expecting to see. So I'll kind of walk through my response to that question, which I think will address the rest of your question as well, Jeanette. So in the previous attempts to create the repository that I mentioned by Sketchfield, there was a lot of discussion around a majority of the data sets that they found not necessarily being useful for further secondary analyses because there are so many changes that happen over time in some of these settings, or because they're so specific or conducted so irregularly that you wouldn't be able to necessarily conduct these kinds of longitudinal analyses. And so I think I was expecting to see more of those types of data sets, but I was relieved that we didn't. And off the top of my head, I don't know how many would fall into that kind of like still one-off category or the category of those that wouldn't be particularly useful for future research because of their timing or because of the very specific content. But it does definitely seem like that problem has been somewhat reduced. And I think that a lot of that has to do with the emergence of PHWinds, which is one of those longitudinal data sets, because this resource is so robust and so specific to a lot of the research questions that we try to answer. And I'm sure many, if not most of us, are aware of its imperfections. I think we could say the same for the ASTO and nature profile data, forces of change, like all those kinds of data sets that we're using very frequently have some potential to be used in this way. But at the same time, I do think that they still have done a remarkable job of filling in some of those gaps that we were seeing more often before.
Yeah, great. All right. Okay. Paula, there's another question for you in the chat. Do you think the expectations of remote work differ by generation? So you noted the age difference of workers that were working remote, yet the interviewees, I believe you noted, were older, so in their 40s. I take a little offense at the term older there.
I'm there too.
Do you think interviewing different generations would help further clarify this changing remote work landscape?
So I think definitely kind of interest in remote work is very generational. And we could see that kind of by the quantitative analyses in terms of tenure and kind of even who was working remotely, because we heard that a little bit different, um, from our interviewees. They said, incoming younger staff were wanting it more versus staff who'd been there and maybe been there pre-pandemic really wanted to come in person because they missed that experience to some extent. So there were these differences we were hearing about. We were really interested for this particular study to understand more organizational impacts of remote work. And so we weren't, necessarily interviewing, multiple groups in terms of their own perspectives on why they might want remote work, et cetera. Although it's an interesting research question. And it's definitely an area that needs more research and exploring to kind of understand what people are looking for. And I think we're hearing so much more now too about what's kind of being missed when we're fully remote, and kind of the value of more hybrid situations. So.
Yeah. I mean, I would be surprised if there are many states that are fully remote at this point. I feel like those policies have been changing fairly rapidly over the last year.
There are still states that are fully remote. I live in one of them.
Really?
Oregon is still, I think, fully remote. There's a couple others that are.
Okay.
So, Yeah. They still exist.
Yeah.
But I still think there's some changes. And we're even, we just had an election, like local elections here in Washington State, and a number of kind of counties that were even fully remote, more urban counties are all, those are all changing all those policies we're seeing
Mhm.
currently. So I think that that's another factor that always influences this for sure. So.
Yeah. Yeah. It's definitely in flux.
Mhm.
All right. Let's see. Oh, okay. We have additional questions. So another part of the question for you, Paula, was around differences from supervisors versus staff. Did
Yeah.
you get at that at all?
I mean, I guess I can just quick add to that in terms of we did look at in the quantitative analyses, we had that in PH wins. We looked at kind of slicing and dicing remote and in person in a lot of different ways and really didn't find huge differences. I think, the bigger differences were kind of where they worked and less kind of the position that they worked in. But I think if you were really digging into it, certain types of public health occupations are likely more conducive to remote work than others, and so you'd probably find more differences there, would be my guess, but not so much within the scope of this study.
Yeah. Yeah. Makes sense. All right, Gabriela, one last question for you that's in the chat, which is around whether or not you think any of these data sets could be linkable. And that might be through similar units of observation, could be through similar codes, perhaps occupation codes, things like that. Are there ways that you think any of these data sets could be synthesized a little bit more?
Definitely yes. That's the short answer. And I do think that that would be really interesting. I definitely think actually kind of doing that crosswalking and linking is perhaps beyond the scope of this work. But I do think that when the repositories are available, we're hoping that that searchability by content area, for example, like the ones that we listed by themes, will make that easier for researchers who are looking to do work on a specific content area, specific geographic area, et cetera. So we're hoping that that's one of the benefits of this study. I also didn't talk about this too much, but there were many data sets that came up that were frequently used to provide context for public health workforce research. So maybe describing the communities that are served by the health agencies. So that's one way that we're seeing that data sets are already being combined and linked. So that's something that could continue to happen. We did notice that a few of the data sets, and this kind of speaks to the last question that you asked, Jeanette, many of the data sets describe, or a few of the data sets rather, describe kind of laws or policies, and we didn't see a lot of work that would link those types of data sets to these kinds of contextual data sets or to PH wins, et cetera. So I think that that would be a really interesting avenue, and especially if those could be updated as these changes are happening in those political realms. So we're really hoping that the repositories provide a starting point to this kind of creative linking of data sets for future work.
Yeah. Well, and certainly we see a lot of researchers linking, for example, and I think this is what you're referring to when you say contextual work. Like we see people linking pH wins with the nature profile, right? Because the nature profile can provide that agency level context, whereas pH wins provides the microdata, the individual level data. And then we could take that up even a further level, right, to the sort of population level, the area health resources file, things like that, that can provide the community context that the agencies are operating within. Yeah, that's great. All right. I don't have any additional questions. We're a little early. So unless either of you have any last comments, I'll give you just a second.
I don't think from me. So
Oh,
glad to be here.
actually, okay. Now I do see one more question that's in the chat. And this is about remote work. So how do opportunities working remotely in the private sector, which seem to be more available, impact the public health state and local workforce? Were there any data collected to see if staff are moving into the private sector? It's a great question.
Yeah, I think so. In our qualitative interviews, that definitely came up, and participants were very clear that staff who were leaving and going to remote jobs, that it wasn't all to the state health department. And that there was kind of this broader movement towards, staff who really wanted to work remotely were finding those jobs in other places. Sometimes it was, so they could stay locally. Sometimes it was to private sector. And I think part of that too came out of, rural local health is always going to be limited in its ability to provide fully remote options. And so if somebody really wants that, it may be that, working in a rural local health department also isn't the best match, which was kind of some of the conversation that came up. I think we did not do this again. Kind of the qualitative piece was more of the focus than the quantitative analyses. In PH wins, when people talk about planning to leave, they can also say kind of where they're planning to leave to. So we don't have actual leave data, actual turnover data there, but kind of a risk of turnover. And you could estimate of those that are saying, one of the reasons I'm planning to leave is because I don't have access to remote work. You could maybe get some sense of that. But outside of that, no, short answer is no, we did not collect that data, but there's some of that data that could be available.
Well, and that landscape is changing as well,
Mhm.
the availability for remote work.
That too. Yeah.
Great. All right, thanks to both of you. I'm going to go ahead and share just a little bit more information here. All right, the CWORPH is supporting a series on fiscal austerity that we invite you to join. The Center for, I guess I should say the Center for Public Health Systems at the University of Minnesota presents a monthly webinar series on fiscal austerity and public health. So please join us for our next installment, which is measuring fiscal stress indicators and early warning systems, and that's April 22nd, and you can register at this link here. And then we want to say thank you for attending, and you can find more information about CWORPH and sign up for our newsletter at these links, and these slides will be distributed after the webinar finishes. Thanks to all of you for attending today. We appreciate it.
Thank you.